At the Leeds teaching hospitals, we aim to put the patient's needs first. The Trust is responsible for over 4,000 transfusions per month. All staff involved with the transfusion process need to be informed of the significance of adhering to the correct transfusion procedures to ensure patient safety. Staff within the Trust need to be aware of the importance of safety issues around blood transfusions and transfusion samples. Staff must be competency assessed in all areas of the transfusion process that they undertake. This film aims to identify the key areas and demonstrate the correct practice required.
It's very important to not make errors during the transfusion process because many of these errors can be fatal or can have a serious impact in the life of the patients. There are risks associated with overtransfusion. Also, if patients are under-transfused, can be at risk to have fatal complications related to the disease.
The decision to transfuse. The decision to transfuse must be based on a thorough clinical assessment of the patient and their individual needs. The decision process leading to transfusion must be documented in the patient's clinical record. There is evidence that suggests that when the reason for the transfusion is documented within the patient's notes, there is actually a lower rate of inappropriate transfusion episodes. Patient's consent. Within the Leeds teaching hospitals, involving the patient in their transfusion care is the gold standard. Informed written consent for transfusion promotes patient involvement as it provides the patient or those with parental responsibility with an opportunity to discuss the reason for and the risks, benefits and alternatives to transfusion. This should be done in a timely and understandable manner. There are many patient information leaflets available to assist with this. Patients or those with parental responsibility must, whenever possible, sign the transfusion consent form before transfusion can commence. If the patient lacks capacity and the transfusion is in the patient's best interest, the doctor should sign consent form 4. If the patient is temporarily too unwell to provide their written consent, then the patient must be offered retrospective information about their transfusion. Patients must be informed that they have received a transfusion prior to their discharge. Valid consent is when the patient or those with parental responsibility have had the opportunity to refuse treatment and discuss alternatives. Where patients refuse the transfusion of all or specific blood components or an advance decision exists, this should be documented in the patient's case notes.
If for any reason a patient cannot give a consent because it is unconscious or it comes urgently in a state that cannot give consent and the doctors believe that it is in his best interest to be transfused, they have the obligation to inform retrospectively the patient about the risks and the benefits of the transfusion that he received. Patients in chronic transfusion programs, they are aware of the risks and the benefits of transfusion. There is no reason for them to consent every time that they get a transfusion. However, there is an accepted practice to renew the consent for us to remind the patient about the risks and the benefits, and also to give them more recent information related to blood transfusions.
Requesting blood. Requesting of blood components may only be carried out by an appropriately trained, competent and locally authorised practitioner in possession of the relevant information about the patient. The name of the person making the request should be clearly indicated on the blood request form. A contact number should also be documented to allow the transfusion laboratory staff to contact the requester if further questions or problems arise. Requests for transfusions should only be sent out of hours when clinically necessary. The serious hazards of transfusion, SHOT reports, show that there is an increased risk of transfusion errors out of hours. As a minimum, the request should have the patient's core identifiers. Gender and diagnosis should also be included, as it's important for blood selection purposes. Failure to fill in the transfusion request form fully may delay the provision of blood and blood components for the patient.
It's always useful for the laboratory staff to have as much information on the request form as possible. So information about previous antibodies or previous reactions that the patient may have had will be useful in order so they can get that blood out to you when you need it.
It's important that medics familiarise themselves with the local policies and guidelines detailing the requirements for transfusion in both routine and urgent situations, and the action to be taken by the transfusion laboratory if the minimum requirements are not met.
The best way to get blood components to the clinical area in a timely fashion is to communicate with the lab. The sooner you communicate with them, the more you communicate with them, the easier it is to get your blood products wherever you need them. So if you're going to move your patient, let the lab know that you're going to move the patient. So if you're going to the ward or you're going to intensive care or you're going to CT, let the lab know as soon as you can. Allows them to organise getting your blood components to you as quickly as possible. And if you communicate them in a timely fashion, so if you know that things aren't going quite right, that you might need blood components, don't wait till it's an emergency. Let them know and let them prioritise their workload, and it means that you're not affecting the rest of your patient care as well, because it's letting them prioritise their workload.
Prescription. The prescription of a blood component is the written authorisation to administer a blood component and is different to the request. Blood components should only be prescribed by an appropriately trained, competent and locally authorised registered practitioner using an approved transfusion prescription form. Ideally, to prevent communication and transcription errors, blood components should be prescribed by the registered healthcare professional making the decision to transfuse. The prescriber signs the prescription form and documents that the patient has signed the blood components consent form. The prescription should include the following: patient core identifiers, what component is to be transfused, date, volume and rate of transfusion, history of transfusion reaction, and if the patient requires any specialised blood components. How to identify a patient correctly? Positive patient identification at all stages of the transfusion process is essential. Patient core identifiers are full name, date of birth, and unique identification number, either NHS number, PAS number, or hospital number. Whenever possible, the patient should be asked to state their full name and date of birth. Patients who are unable to identify themselves, their identification should be verified with a parent or a carer if present. This information must match exactly the information on the patient's identification wristband. All paperwork relating to the patient must include and be identical in every detail to the minimum patient core identifiers contained on the patient's wristband. The transfusion request form should have the core identifiers detailed. The clinical reasons, the urgency, and if any special blood components are required, should also be annotated on the form, as this enables the laboratory to prioritise efficiently. Taking a blood transfusion sample. Throughout the transfusion procedure, any staff involved must adhere to the local infection control policies and ensure that they have personal protective equipment, PPE. A 7 ml EDTA pink-topped sample tube is required for all routine transfusion requests. The patient is asked to state their full name and date of birth. The person taking the blood sample checks these details against the patient's wristband. The sample is taken at the patient's side and is labelled at the patient's side with the patient's core identifiers immediately after the sample is taken. The equipment is disposed of accordingly. The sample is then sealed securely in the plastic bag attached to the completed transfusion request form and sent to the blood bank laboratory. The transfusion laboratory staff check that the sample is filled in correctly against the request form and enters the information into the laboratory database. The Trust operates a zero-tolerance policy for mislabelled transfusion samples. Any mislabelled samples will be disposed of and a new sample will be requested.
Samples should be taken and labelled correctly according to all the national guidance in order that we get the correct sample down to the lab and then they can test it and it is tested against that patient's information. If a sample is labelled incorrectly, the transfusion laboratory will reject that sample and request a new one. They will not accept or issue any blood on a sample that is incorrectly labelled and does not match that patient's details.
So an unlabelled sample often means that we have to rebleed a patient, which is often really, really difficult, especially in trauma patients, because often they are hemodynamically compromised and really difficult to get blood from. And so if we have to rebleed a patient, it often causes a major delay, and it means that patients who are really, really sick don't get the blood products that they need in a timely fashion. And so it can really impact on patient care.
Before the transfusion can commence, ensure that the patient is ready to start the transfusion, has patent venous access, and has signed the transfusion consent form. Baseline observations of blood pressure, temperature, pulse and respiratory rate must all be recorded and documented no more than 60 minutes before starting the transfusion, ideally before sending for the blood. The appropriate blood-giving equipment and PPE must also be available. If the patient is not feeling well, or if the observations are uncharacteristic of the patient's condition, it may be prudent to delay the transfusion. Collection. When collecting the blood component from the laboratory or blood refrigerator, a trained and competent healthcare worker should take 3 written unique identifiers pertaining to the patient and check these with the compatibility label on the blood component. The removal of the blood component from the laboratory or blood refrigerator is recorded on the blood track system. Members of staff should only ever use their own ID cards when accessing the blood track system. The component should be delivered to the clinical area without delay. Upon arrival within the clinical area, the component should be handed directly to an appropriate member of staff who will then check the correct blood component has arrived for the correct patient, and then record the unit of blood as arriving onto the clinical area by using the AutoFate system. Giving a blood transfusion. The final pre-administration check must be conducted at the patient's side by 2 trained and competent healthcare professionals, one of whom should also administer the blood component. All patients receiving a transfusion must be positively identified and must be asked to state their full name and date of birth before every transfusion. All patient core identifiers on the patient's wristband must match the details on the blood component compatibility label. If a patient does not have a wristband, then they cannot have a transfusion.
Independent checking of the blood component at the bedside is important. It is the last stage that we can recognise that there has any errors been taken place throughout the process.
The blood group on the blood component should be compatible with the patient's own blood group. If for any reason this is not the case, then the blood bank laboratory must be called for advice before the transfusion commences. The expiry date, consistency and colour should also be checked at this point in the process. The peel-off section of the compatibility label should be placed on the transfusion prescription. All blood components should be administered using a blood administration set with an integral filter of 170 to 200 microns. The line may be primed with 0.9% sodium chloride prior to the transfusion. Nothing should be added to the blood component. Transfusions must be completed within the time limit which complies with national guidance. The time that the transfusion commenced and volume transfused must be documented. Observations should be taken for every unit transfused. Minimum monitoring of the patient should include regular visual observations throughout the transfusion episode. Pulse, temp and blood pressure should be taken 15 minutes after the start of each component transfusion and repeated post-transfusion. If these measurements have changed from the baseline values, the respiration rate should also be taken. More frequent observations may be required depending on the patient's condition. Mild transfusion reactions. A mild transfusion reaction is determined if the patient has temperature rise of less than 2 degrees Celsius from the baseline, and/or the presence of an urticarial rash. If the patient appears to be suffering from a mild transfusion reaction, it's advised that the transfusion is temporarily stopped and symptomatic treatment be administered, such as paracetamol for the temperature rise and antihistamine for the rash. The transfusion should then be restarted at a slower rate, and the patient should be closely monitored. Severe transfusion reaction. A severe transfusion reaction is determined if the patient has temperature rise greater than 2 degrees Celsius from the baseline, and/or any life-threatening symptoms. The transfusion must be stopped immediately. The patency of the IV line should be maintained and seek urgent medical attention. Any further observations should be documented on the routine observation chart. The blood bank and hospital transfusion team should be informed as soon as possible of a severe transfusion reaction. The blood bank will require the blood component to be sent back to the laboratory along with any used or unused units. The laboratory staff will advise the clinical team as to what samples should be taken from the patient. The incident should be recorded on Datix Web and marked for the attention of a member of the hospital transfusion team for investigation and onward reporting to the appropriate agencies.
Patients need observing throughout their transfusions. A lot of them are very unwell anyway, so in that case then we need to make sure that we're not doing any further harm to our patients and keep them safe throughout that process.
Completion of the transfusion episode. It is a legal requirement that any organisation that performs transfusions must be able to identify which unit of donor blood has been administered to which patient. The Leeds Teaching Hospitals uses the AutoFate system to ensure compliance with this law. The used blood component should be disposed of straight away in accordance with the Trust's infection control policy. To make sure that the patients within the Leeds Trust receive the best possible care during their transfusion therapy, it is vital to remember positive patient identification, safe monitoring of the patient, auto-fating of all blood components.
Finally, I would like to emphasize that the medical doctors, and in particular the consultants, are responsible for the whole care of the patients. Therefore, they should know all the stages involved in the transfusion process. They should know how to supervise them and how to explain them to the patients.